Hello everyone, I am Dr. Anupam and I will be your instructor today. Today we will discuss about the comparison between volume control ventilation and pressure control ventilation. Now this lecture will only be valid for all of you if you have already watched the individual classes on volume control ventilation and pressure control ventilation. If you have not watched, please follow the link and see that, then come back here again. So coming to our discussion, I have already written down the 7 key factors in differentiation between volume control ventilation and pressure control ventilation, so that we will not miss out on anything. So before starting on the difference, I'll just define these two modes of ventilation. The volume control is volume controlled, time or patient triggered, flow limited, volume or time cycled ventilation, right? So how to define PCV? Same thing, pressure controlled, time or patient triggered, pressure limited, time cycled ventilation, right? Now we will discuss about the differences. So the first point is minute ventilation. So what will happen in volume control ventilation? Because it's volume controlled, so tidal volume is fixed, and that means minute ventilation is fixed, and that means we have control on ventilation or PCO2 level, right? What happens here? Here tidal volume is not fixed because we have fixed the pressure only. So minute ventilation is variable. So we do not have a control on minute ventilation or PCO2 level, right? Coming to respiratory mechanics, tidal volume or minute ventilation does not depend upon resistance or compliance of the respiratory system, right? Because you have already fixed the value, so whatever happens, that volume will be delivered. What happens here? Here tidal volume or minute ventilation depends actually, because you have set the pressure. If there is a king clot or secretion in the airway, in the AT tube, the pressure will be achieved earlier. Because there is high resistance, pressure will be increased, so tidal volume will not be delivered, patient will hyperventilate. It depends upon respiratory system, resistance or compliance, right? Now we will observe the flow time scalar. How the flow time scalar looks in volume control ventilation? It is a square form like this, correct? Square waveform. The advantage of this is, in the beginning flow is minimum So what that will do, that will not produce a high peak airway pressure alarm in the beginning when you are dealing with a high air resistance, right? But the problem here is flow is fixed and low. So when the demand is high, it will not be able to provide that flow to the patient. So there will be a synchrony because flow is fixed, is flow limited, flow is fixed. What happens? The same flow time scalar in pressure control ventilation, it will look like this. Because it is pressure limited, so initially the flow will be high to achieve that pressure. Then to maintain the pressure at that level, the flow will decrease, so it will produce a ramp waveform, right? It's called ramp pattern. The advantage of this is because it is a high flow in the beginning, and plus flow is not controlled here, flow can vary, so it can produce good synchrony, right? And the problem will be because initial flow is very high, so what will happen? It may tip off high peak airway pressure alarm and abort the breath in patient where we are dealing with high air resistance. Then coming to the pressure time scalar, how the pressure time scalar will look in volume control ventilation, because you know that pressure is a variable, dependent variable in volume control ventilation. So pressure will have a slopy kind of wave pattern and it will vary from breath to breath, slopy. But here the pressure time, this is the here, because your pressure is controlled, pressure will be maintained at a certain range, then it will come down to acceleration. So this will be slope, this will be constant waveform. So what is the advantage? Because it goes up then come down, the mean airway pressure will be lower. Here the mean airway pressure will be higher because pressure is maintained at a certain level. So advantage, disadvantage is mean airway pressure is lower. Here this become advantage, mean airway pressure is higher, right? So that means what? Oxygenation is better. So we do not have a control on the ventilation, but we have a control on the oxygenation in pressure control ventilation. So oxygenation will be lower. Second advantage is recruitability. You can see the pressure is rising, then cycle to acceleration. So there will be some alveoli which will be having very low compliance, they will be stiff. So they require pressure, high pressure for a sustained period of time to get inflated. But you can see as soon as they have pressure is the maximum, at the next moment it is cycling down to acceleration. So there will be some lung which will remain de-recruited. De-recruitment is high. However, here pressure is staying maximum for a certain period of time. So here recruitment is better. Again it will cause oxygenation better. Again it will cause lower oxygenation. So you can see when you choose for ventilation support, for example neurosurgical patient where you want to have a PCO level of certain range, PCV is better. But where oxygenation is your primary concern, then PCV may be the mode of choice. What happens to barotrauma and volutrauma? Because it is volume controlled. So volutrauma and barotrauma can be there both, because pressure is not in our control. Here barotrauma is minimum, but when compliance improves, the same pressure can give rise to high volume, producing volutrauma. Right? What happens in the presence of a leak? See, because the flow is limited and you have set the flow at, for example, say 40 liters per minute. So what happens in the presence of a leak? For example, when you are doing bronchoscopy, or when you are doing a suction, or there is a bronchoalveolar fistula, what will happen? There will be some flow leak. Now remember, if the flow leak is 40 liters per minute and you have also set the flow limit of 40 liters per minute, that means the ventilator cannot increase the flow beyond 40. So all the flow you are giving is getting leaked away. So patient will be hyperventilated. So it is not a mode of choice when leak is present. What will happen? Patient will hypoventilate and there will be decrease in mean airway pressure. But not here, because here you are not setting the flow. The flow can vary. So even if there is a leak in the system, the ventilator can increase the flow to maintain the pressure level. So mean airway pressure is maintained. Again, it's an advantage for providing better oxygenation, and a tidal volume will be delivered. So in case of, for example, preferred mode when leak is present, BP fistula during bronchoscopy or suctioning. Coming to synchrony, volume control ventilation synchrony will be not that good in comparison to pressure control ventilation, because flow is fixed. When patient requires high, it cannot be given. So this will produce a asynchrony. Flow is variable, so better synchrony. Another reason for better synchrony is a ramp. A ramp waveform produce better synchrony. Here square waveform produce asynchrony, right? So now we have discussed in detail what is the difference between volume control ventilation and pressure control ventilation. Now depending upon these things, you can choose for a patient what he requires. As a golden rule, remember, if ventilation is your primary goal, choose volume control ventilation. If oxygenation is your primary goal, choose pressure control ventilation. We have discussed in terms of minute ventilation, second respiratory mechanics, third observing the flow time scalar. I'll just delineate for your advantage. Then we have discussed the observing the pressure times scalar, what we can learn. Then we have discussed regarding the barotrauma or holotrauma, what happens in the presence of leak. Then about synchrony. Thank you very much. I'll meet you in the next class.